Hi guys, it's Alexa and Zoe. We're here to help you guide you through care plans, concept maps, and med cards.
So in our little video, we're going to be talking about the different parts of the care plan, which you see on this page. And then we're also going to talk about nursing diagnoses a little bit and how to build a concept map, and then just tips and tricks for filling out your care plans. So this is what the care plans we used for MCA 3. So they're a little bit different than what you all are going to be using for MCA 1 and 2, but it has all the same information. So at the top here, you put, your name, the date that you were taking care of the patient, the unit, the patient's room, and then their initials. You just want to put their initials. You don't want to put any information that would be a HIPAA violation. So here I also have the admit date, the length of stay, and then some patient demographics. So age, sex, height in centimeters, weight in kilograms. It's very important that the weight is in kilograms because that's what you use when you're calculating your urinary output or when you're giving meds. And then the BMI. Another important section is the allergy section right here. My patient didn't have any allergies. That's what the NKA stands for, no known allergies. But if they did have allergies, you'd want to put them here. There's a lot of common drug allergies or food allergies that you want to be aware of. Their code status you would also put here, and then if they had an advanced directive. So this first section right here is the diagnosis and the history section. The current diagnosis is their reason for hospitalization. So my patient was hospitalized due to chest pain and syncope that was lasting for 3 hours. If my patient had surgery, I would put that information here. The history of the present illness, so what led them to coming to the hospital. So my patient had 3 hours of dizziness at home that didn't go away. And then other medical or surgical comorbidities you could put here. So he had bilateral neuropathy in both feet, a history of alcohol abuse, hypertension, and severe aortic stenosis. I also have the isolation precautions. So he was standard precautions. He didn't have any infectious history, and it was not an active issue. Here, the social history, his primary language was English, no need for interpreter, and then his caregivers were his 2 sons. Activity orders are down here. So he was up ad lib as tolerated because, he was having the dizziness, but then he did have an angio that day. So coming back from that, he was on strict bed rest with the head of the bed less than 35 degrees. Here, he also was a fall risk. We had a bed alarm on, and he did use a walker, no need for restraints. And then, so this section over here is where you're going to put in all of your vitals. And then down here, we have the diet orders. So he was NPO because he was going to a procedure. We have the last bowel movement date. That's really important. Depending on what facility you're in, if they don't have a bowel movement in a certain number of days, they're going to need to go on bowel care meds. So my patient was on bowel care meds. He was not a diabetic, so there's no need for fasting blood sugars. And he was not on any sort of tube feedings. This section right here is your lines, drains, airways, and tubes. Typically on your medical surgical floors, you're not going to have patients who are intubated. Very rarely that happens, but sometimes you will have those patients, so you would document all of that here. Same thing if they have a GI tube or a PEG tube, a tracheostomy. Here we have all of our lines. So when you chart your peripheral IVs, that's all going to go right here. So the number that they have, the gauges of each one, the location of each one, and the dates that they were inserted. This section over here is also important. You want to make sure that those IVs are patent so that you can flush them with your saline flushes. You want to assess for if there's any, phlebitis or infiltration, swelling, tenderness. And you also want to look at the dressing change to make sure that the dressing is clean, dry, and intact. If they had a central line, you would put that here. Art lines you're only going to see really in the ICU. You might see patients with dialysis ports, so you could chart all of that here, or if they have any other vascular access devices. And then on this page is where you would put if they were on any continuous IV infusion. So if they were on normal saline, or if they were having, you know, a blood transfusion or something, you would put that all right here. Then you have your I&O section, so what their intake is, their output, and then the net. And then on here you could find the expected urinary output by multiplying 0.5 mils per kilogram per hour. So you can see here I multiplied his weight in kilograms by the 0.5 mils, and that's the expected urinary output.
Okay, so here's an example of your med cards, and on the left, as you can see, is the general information. On the right is the patient specific. So these help with your med rights and also just your knowledge of your medications. So going over your med rights, you should have the right patient, you should have the right route, like are you giving it subcutaneously, is it intramuscular injection, is it an IV med, is it per oral, and there's several other options as well, like a suppository, for example. Is it the right dosage, and is it in the right units? And also you should know the right time, not only frequency, but also what time of day it should be given. Is it like every 12 hours or when it was last given? And then finally, the right documentation. So as you can see on the left side, you could fill out with your drug book, or and just these are more standard values, like you should know the generic name, and then also there are several brand names per different pharmaceutical companies. You should know your safe range so you don't overdose a patient. You should know what type of meds you're giving. That's very important for clinicals when you're working under a nurse, because you really shouldn't give a med to any patients unless you know what you're giving and why. And so these med cards are very helpful for that. So why are you giving them, which should be under like the indication section, and your dosage should be under the dosing. Your frequency should be under the duration, and how soon you should see or expect the med to work. So for a lot of per orals, it might be a 30-minute onset, but it's all in your text, your drug books. So on the right side, you should say why it's pertinent to this patient specifically. So here's some filled out examples. This top card is a common antibiotic, ciprofloxacin, which we call Cipro quite often, abbreviated. You should know the safe range so you do not possibly cause any kidney damage or any other just medication toxicity issues. And it is nice to know the mechanism of how it works, and this is all in your drug book. You should know the range and how you're giving it. This one is commonly an IV drug, but it could be other routes, and that does control what type of dosage you're giving it, because the IV might be a smaller dose than an oral dose. So it's very important to put. And you should know your side effects and the possible adverse effects and contraindications, because maybe that means you should be giving a different medication instead if the patient has a history that rules out this medication for them.
So this page is your nursing diagnoses page. So you always want to make sure that your first problem that you put is what's most related to your patient, or what's the priority. So for my patient, my problem 1 was decreased cardiac output. That's my nursing diagnoses. I put that because he did have shortness of breath that lasted 2 to 3 hours. And then my supporting data was that his angio showed aortic stenosis and increased blood pressure to compensate. So next to that, I have my patient outcomes. So these are things that I want the patient to meet during my clinical time with him. And my interventions are the steps that I'm going to take to get these outcomes that I want. So you can kind of take a look at that here. And then my second problem, I put activity intolerance. You know, he did have that history of dizziness at home that was unusual for him. It lasted more than 3 hours. So my data, like I said, that supports that. You know, he needs a walker in the hospital. He doesn't use one at home. And then again, my outcomes and the interventions, or the steps that I'm going to take to reach those outcomes for him. And then my third problem, he is at risk for falls. You typically don't want to put your risk fours as your priority 1 or 2 nursing diagnoses. This is more of a preventative um, diagnosis. Like again, he does have that syncope at home, so he is at risk for falls. He does use a four-wheel walker that he doesn't typically use at home. He's dizzy when he's changing positions in bed. So again, I have my outcomes listed here. These are the goals that I want to set for my patient, and then my interventions on the side as to how I'm going to reach those goals for him. And then you have this little section down here what has to do with the overall plan of care for your patient. So for him, we wanted to make sure we were monitoring his puncture site coming back from an angio. We had to keep his right leg straight for a minimum of 3 hours. We wanted to track his blood pressure to make sure they were trending down. He was very hypertensive at one point, so we want to make sure that the medications we gave him are helping his blood pressure to trend down. And then we also know that because of his aortic stenosis, he is going to need an aortic valve replacement at some point, and he will also need bypass to help improve that cardiac output. And that was all explained to him by his cardiologist. And then this little section at the bottom just has to do with your concept map. So these are the different things that are required for your concept maps. And then this is your tele strip. You're not always going to have patients who are on tele. You'll typically get into this more during MCA3 on how to interpret strips and whatnot. But right here, I just always put the patient room number and the time for me when I print the strip, just because you don't want any patient identifiers on the actual strip when you put it onto your care plan. I think that's pretty much for that. Like I said, you'll get more into this during MCA3 on how to read strips, but it's just good to kind of get into the routine of printing a strip and adding one to your care plan, as long as your patient's on tele.
Okay, here's an example of a care plan I did. So once again, at the top, this is the biographical information or intake information that you get. And the allergy section is very important. And for this patient in particular, he was a psych patient. So Ativan is a common psych med if someone's agitated, and he just happens to be allergic to Ativan. So it's good that's listed here. Like Zoe mentioned, it's good to have the weight in kilograms for any medical dosing or when we expect urinary output or any fluid input. We need to make sure our patients are hydrated. And BMI, which is normal for this patient, is important. It's an opportunity for educating your patient, maybe to control their weight or if it's a possible cause of their current condition. Once again, code status is important. Should you be doing CPR on your patient or not is a very important issue that you should be aware of, and it could even become a legal one. So here's the diagnosis and history, which is basically part of the SBAR. This patient in particular came in after he jumped off a bridge due to him having a schizophrenic, I guess, help me out, Zoe, what do you call this?
Like an episode?
Yeah, or I guess we're in psych right now, so I should get the right terminology. But so as a result, he was chasing something off a bridge. And so he had bilateral tib-fib fractures, as I wrote for the current diagnosis, what he's being treated for, and his liver and spleen were lacerated. And then the surgery he needed was the investigational laparoscopy, splenectomy, and external fixation of his tib-fib fractures. The history of the present illness was a standing psych issue with suicidal ideation, or SI, and he was on a 5150 hold, which is important because you'll see at the bottom for the orders, he had a sitter as a restraint. And also it's important to make noted the isolation and infection history, and if it's active or not, because those are PPE things you should know before you walk into a patient's room. The social is important once again. Who's your patient's caretaker? Who are you discharging them to, and who are you communicating with? And what language they speak. They need an interpreter. So for the activity orders, this patient was on bed rest and spinal precautions because he actually did tear ligaments in his spinal cord, or in his spinal processes holding his spinal cord together. And he needed a wheelchair, which was through PT, and he had the sitter for his suicidal ideation. And then as you can see, all the vitals are filled out. And it's important to note under the O2 amount and device, because that delivers different percentages of oxygen to the patient. And then also their dietary orders are important, especially if they're diabetic, if they're even allowed to have anything, because if they're expecting to have surgery and you give that patient water even, that can delay their surgery. Or if they just are not able to swallow anything, you can put that patient in danger of aspiration. So it's important to put down your diet orders. And then once again, the bowel movement date is important because a patient can't be discharged sometimes until they've had a bowel movement after a certain amount of time. And the fasting blood sugar is important because you should be taking blood sugars before diabetic patients are given certain meals. And yeah. So this is part of the MCA3 care plan, which is not in your care plan, but it's nice to look at because it kind of shows how people are given report. And this is a very nice head down like order. And it's basically part of an SBAR as well. And I liked writing my SBAR in this format. And everyone will figure out their own different ways of their brains, how they like to format everything to collect all the information from a transfer of care. So I liked this quite a bit. And it's basically your head to toe right here. So here's a page that resembles yours. I think it's missing a couple of sections, but these are this patient's lab values, which are consistent with his injuries. He did have low red blood cells, low hemoglobin, and low hematocrit due to the blood loss from his fall. And he had low sodium, and I got some assistance online. So that could be from decreased liver function and dehydration, which makes sense because he did have a liver laceration, so it's decreased. And the glucose is elevated, which is a response to trauma. And these values, these ranges are per hospital policy. They're different amongst different hospitals. Different hospitals are more worried about different values or more conservative than others, but your textbook is what you'd use for your exams in class. Okay, and then this is just diagnostics, and this patient clearly had x-rays done to see what damage he had caused to his skeleton, which is all outlined here. And then for the MCA3 format, we had to put more medications down, I believe, and this is just an extensive list of all the meds he was on, and a lot of this information transfers over to your med cards. Okay. And so here's the filled out med cards, and I chose 2 of his medications, the antibiotic, which I talked about earlier, and a second one called Haldol, which is an antipsychotic that this patient was on. And as you can see, it's filled out as to why we're giving it to this patient, the dosage, which is important because as you can see, the dosages are different for the IM versus the per oral, and what it does, because that can maybe conflict with another medication. And it's good to know why it's contraindicated, any side effects, like if a patient starts acting a certain way, we could refer to the medication we gave and maybe associate the two. And any effects that might be a result of the medication, which maybe might even make us give them another medication to resolve that. So here's a concept map for this care plan. And basically in the turquoise blue, those would be your nursing diagnoses or priority problems. And then from there are the desired outcomes or the reason why we are even doing those. And as you can see, I labeled between the arrows basically like flow words like as evidenced by, leads to, treated by, prevented by, which might be like a risk for, it is risk for, DVT. And it's nice, I like to make mine on Google Drive through diagrams.net, which you can download. And I'm not a very neat person, so I liked typing everything in. And a professor told me once this should be like your plan for the day and why you're doing it. And I kind of liked thinking about like that.
So this is an example of one of my care plans. It's not as nice and organized as Alexa's, but I did this one just on my iPad. I like being able to draw it out. It helps me make those connections with my patient. Like, as you can see here, you know, my patient is having airway inflammation. Oh, that's why I'm giving the Solumentrol and the Robitussin. Or, you know, my patient had, you know, red blood cells that were super low. So that's why we were giving 1 unit of PRBCs. So I like to be able to draw it out, like I said, just to make those connections. But as long as you have your key and you're labeling different things, really you can just do it whatever way works best for you. So these are just some tips and tricks for filling out your nursing diagnoses. So you always want to ask yourself, what is the problem in your care plan? What is a problem that your patient is having that is a goal for you to try to fix? So the NANDA book is really helpful. I also like using the clinical companion that goes along with your med-surg textbook. If you can find the clinical diagnosis for your patient in the book, typically it'll give you some different goals or nursing diagnoses, different outcomes for your patient if you're feeling a little bit lost. And then I would also say to try to have, you know, at least 2 actual problems and a risk for, or even better, 3 actual problems, because that's really helpful with your interventions and your outcomes. And then make sure with your interventions that they're timely and that they're measurable. So some examples we have here is that you can put that you want to achieve your goal every 2 hours or 3 times a day, or you can put by discharge or the actual date. So there's a few different ways that you can make your goals timely and measurable. And I think that's pretty much it. So if you have any questions, you can always email us about how to do your care plans. I'm sure Renee will talk about it more in class, and then as you go on, you'll be able to make your care plans. And it does take practice, it does take time, but your clinical faculty will also be able to help you when it comes to making those care plans. And I think that's it.